I'd like to welcome you all this evening. I'm Susan Irvin, the co-coordinator of the League of Women Voters, along with Macon, who's the other co-coordinator. It's great to see some new faces tonight. The League of Women Voters in Macon County has been here for how many years, Macon? It's 1990? Okay, because that's a while. The League is a national, state, and local organization. We're nonpartisan. The League was founded in concert with the women's suffrage movement, and we have always represented women's rights, children's rights, civil rights in general, voters' rights, voter education, voter participation in government, and those are the things we emphasize here in our Macon County Chapter 2. For many years, we have met at Tartan Hall at noon on the second Thursday of every month and had informational programs. And we decided to try changing our schedule a little bit, try changing our format. We're going to have a series of forums this year, and they're going to be held here in Town Hall, and they're going to be in the evening instead of the daytime. And it looks like we have gotten some opportunity for some different people to come out and hear us tonight, and we're very pleased to have you here. Some of the other forums on July 9th, we're going to have a forum on North Carolina tax policy and its effects on services and various things in the state. On September 10th, we're going to have a forum on North Carolina voters' rights. And on October 8th, we will have a town election forum. So we hope to see you at all of those, and thank you so much for coming tonight. I'm going to turn this over to Nancy Scott, a longtime League member, and she's the one who organized this wonderful panel to talk with us tonight. So thank you so much, Nancy. I did not organize this by myself. I want to thank Mary Ann Whitinghouse with the National Alliance on Mental Illness and Cindy Solsby with the Affordable Care Act, and Andrea also with NAMI helped us get together and make plans for the night. I want to thank Christina for getting out the word and other people that sent out the word. Thank you very much. It's wonderful to welcome all of you here. I wanted to say a few words before I introduce our panel. I think we look at mental health on a continuum from optimal mental health, mild distress, severe distress, and crisis situation, just like physical health. But we tend to take our mental health for granted until there's a problem. We all know someone who is dealing with or has dealt with a mental health problem. And we learn from the media the need for more education and more resources for mental health. We also learn about the tragedies that can result when mental health issues go unaddressed and untreated. We know that our prisons and our homeless shelters are overcrowded with a large percentage of people with mental health issues. And we say people are the most likely to be abused in those situations. We know more of our children are experiencing mental health issues than in previous generations. And we know some of the factors that can precipitate mental and emotional disorders, such as prolonged or acute stress, family breakup, violence, abuse of drugs and alcohol, and name something. We know what good mental health looks like: a sense of well-being, the ability to learn, to express and manage both positive and negative emotions, and to form and maintain positive relationships, and to be able to cope with and manage change and uncertainty. We also know that a strong, supportive community environment can help people cope with mental health issues.
everything from depression and anxiety to bipolar disorders or others or eating disorders. Research to learn what's going on in Macon County and in Western North Carolina to promote mental health and provide support to our families dealing with mental illness. We have a panel of experts tonight, and I'd like to thank them all for being here. From Smoky Mountains. Okay, all right. We have Rhonda Cox. If y'all kind of raise your hand as I introduce you. She's the Senior Director for Care Coordination. We have Ann Dupree Rogers, and she is the Community Outreach Director. And we have Kate Lance, who is the Outreach Specialist. From the National Alliance on Mental Illness, also known as NAMI, we welcome Danica Klein. She's the president of NAMI, Appalachian South, the local affiliate of the National Alliance on Mental Illness. And Mary Ann Whitehouse is the past president and membership chair and educator for NAMI. We have from the Sheriff's Department, Mr. Steve Stewart. He is going to tell us about what happens in the detention center, the Sheriff's Department. From the Mental Health Task Force, we welcome the chairman of that church, Mr. Ron Beal. And finally, we welcome Cindy Soulsby, who is the local navigator for the Affordable Care Act. We thought we would try to limit the speaking time so we'll have time for questions. So each entity, I've allotted 15 minutes. If you don't need that much, that's lovely, but if you need a little more, maybe somebody will be generous and share. And we have our sheriff, Mr. Robbie Holland, is going to be our timekeeper. So
this is going to be fun.
And we have some more chairs over here. There are two here, one back here, and we have some people maybe coming here, maybe not. I guess they decided to go there. We also, when we finish up, there's lots of literature back here where the aldermen and mayors sit that they've spread out on the table there for you to pick up your papers. So, so with no further ado, I guess we'll start and let's go from, yes.
Do you want me to give them a warning about the 15
Oh, yes.
minutes? Like 1 minute?
Yeah.
5 minute warning.
Maybe draw your gun.
Yeah. Now those three are sharing.
Right.
And these two are sharing.
We've already took 2 of their minutes.
So we're going to try to give just a brief history for those of you who may not be as familiar with Smoky Mountain Center and its relationship in the community. And then Ann's going to talk a little bit about things that have happened over the course of last year. And then if we have a couple of minutes left, we'll talk about what we anticipate coming in the future. Can everybody hear me okay in the back? So Smoky Mountain actually started in 1965 as a local mental health program, and then in 1972 was known as what was a local management entity and serving the 7 westernmost counties. And then over time, we've grown to 23 counties. In 2012, we became responsible for managing the Medicaid dollars, as well as serving as insurance for people that don't have any other type of mental health insurance, and then also managing public dollars that come through the county. And we serve all 3 disability groups, so if someone had a mental health treatment need, a substance use treatment need, or if a person had an intellectual or developmental disability and needed services, they could get services through Smoky Mountain. As many folks know that have been anywhere near the system, there has been a lot of change and transition. We went from kind of local community mental health centers to then we went into something called privatization, which the idea behind that was to give people choice. But what they found in many rural communities was what that really did was limit service availability. And so over the past decade, there's been quite a bit of work done to try to stabilize and assure that even in small communities, that the range of services were available for individuals who needed treatment or who needed support services if they had an intellectual or developmental disability. So as I mentioned before, we currently serve 23 counties. So all the way out to the Cherokee County and probably our easternmost county is Wilkes County. We served this year about 1,561 individuals on the innovation waiver. For those of you who are familiar with the old CAP MRDD waiver, that's what that is. And that's kind of the upper end of folks that are trying to be supported in the community that have an intellectual developmental disability. We also serve other people with IDD who are not on the innovations waiver. And then we've served about over 163,000 people this year on the Medicaid waiver, and then 137,000 people that are not insured. One of the things that's unique about Smoky that's different than any other LME MCO in the state is that we serve more uninsured people than any other MCO. And that may not seem like a big deal, but when you think about the percentages of budgets, it's kind of like your checkbook and the government's checkbook. That's sort of the comparison between state funds. There's very limited state dollars, and then Medicaid is a much richer benefit. There's a lot more dollars associated with it because it's an entitlement. And when you think about Smoky, in the old days, we used to be a service provider. And then today we've become responsible for managing the network, or managing different private providers across our counties to ensure that there's at least one comprehensive care center and availability of a full continuum of services for both adults and children in every county to have some level of service. And most counties were able to pull that off, but in some of the really tiny counties, I think sometimes Swain certainly feels this, or Graham feels this, they don't always have the same number of services, but there should be a service close that gets next door, like in a Cherokee County. Macon County is actually really well represented for the amount of mental health services that they have. When we started a while ago, coming back from having privatized, there was a real challenge with having adequate children's services. Today, there is a combination of what we think of like the traditional services, where you see somebody in individual therapy, basic benefit. There's also services that go out into people's homes, like intensive in-home for children that have really high clinical needs. There's services like day treatment in the school system now, and I can remember when that used to be a really bumpy thing. And that's stabilizer services in the school to help support children in that way. There's also intensive outpatient that serves adults who have high needs with substance use or substance dependence, and a variety of other things. It's not a perfect system, and there will always probably be more need than there are resources to serve every single individual in the community. But we've always believed that the way that you do this is you leverage your partnership with your community partners. And so we've worked really closely with juvenile justice, with social services, to try to identify children and families early in the process, to try to keep them out of the crisis services, because we know that's where a significant burden comes in the county, is when you have people that get kind of stuck in the system, end up in your emergency department. Sheriff's Department spending a long time with them, and we're trying to actually get them into an inpatient hospital bed, and that is an area where we don't have the number of hospital beds or inpatient stabilization services that we usually have. We're building to expand capacity in that. We have a service called facility-based crisis, which is hopefully one of the things that you try to do before someone goes into an inpatient setting. Sometimes you can't always stop somebody going through that, but facility-based crisis for somebody who doesn't need the absolute most acute clinical service, that is a place that can help someone stabilize who's having a really difficult time. And there's going to be another, we have one in Balsam. There's another very large facility that has a very different capacity level that is now being built and developed in Buncombe County. There's an additional facility-based crisis coming up in Caldwell County, and you might be thinking, man, that's a long way away from Franklin. And get stabilized and then return home to their home community where they can get wraparound clinical services. That's a much better outcome than ending up getting shipped across the state. It's better for the person who's in the process, and it's also better for the community partners who we have that have to bear the burden of cost for transportation instead of the city. So that's kind of the nuts and bolts pieces. I think when you think about Smoky, we're a public entity that functions like a private organization, kind of like a public hospital or a public university. We do still touch community members. We still work with consumers. We just don't provide direct services. And I'm going to let Ann share a little bit about what some of the things are where we actually do a little bit more community and hands-on service contact.
So one thing that not everybody knows about Smoky is we do spend a good bit of time doing prevention and education, kind of outreach activities. We teach a lot of classes around the catchment area, and they are offered at no cost to community members. We teach classes that help people learn about mental health and mental illness, and in so doing, help to destigmatize those topics. One of them is mental health first aid and youth mental health first aid. I think I recognize a couple people that were in that class a few months ago. We teach something called the community resiliency model, which I think pretty soon we're going to have one here. That's all about building resiliency in communities, so teaching some really simple but very effective stress management to people, and then teaching them how to teach that to others. So you come take the class, you learn some skills, and then you go home and you tell your friends and family about what you learned, and everybody has better coping. You don't have to be a therapist, you don't have to be a doctor to learn the skills or to teach the skills. So that's one of the classes we enjoy teaching, and several others. Well, another one is the WRAP class, the Wellness Recovery Action Plan, which helps people maintain their recovery and make plans to be in recovery as long as possible. So I think that's sort of the gist of it, but Smokey is really committed to the prevention side of things, to the education side of things. We believe very deeply in the potential for recovery for most people when help is received early, and we believe in communities being able to really support one another. What Rhonda was mentioning about people ending up in the emergency department, sometimes that could be avoided by earlier intervention. So things like mental health first aid, where we learn to support each other way earlier, so maybe the hospital never has to happen. But thank you.
How many minutes do we have left? 6. We're doing well. So in the last piece of that, we have Smoky also, because we started in small communities, and particularly in the Western, one of the commitments that we also have is that we have community-based staff in every county, regardless of the size of the county. And the reason that we did that is as many of you guys know, as businesses get larger, sometimes it can be really easy to lose touch with what's happening out there. And so there is actually a commitment to have people, the clinical staff as well as community education staff, in those local communities to be able to stay in contact and in connection with the local providers in each county, and also with the community stakeholders that are part of the team in helping support and identifying where are gaps, where are problems, where do we need to fix, what do we need to put in place next, is this working, is it not working. And I think what we found is that when you have people out there with us, they'll tell you. They'll tell you more often than not when it's not working, but you also, it gives you a chance to see what does work well. I think in the future, for those of you who are following the news, there's a lot of discussion about the role of mental health and what's coming. There are things called accountable care organizations, which are related to the Affordable Health Care Act. And I suspect that is probably one of the next big political conversations. What that really means for the community is that Medicaid costs, if you listen to, regardless of your politics, Medicaid costs have continued to climb nationally for over the last decade. You cannot sustain an entitlement service budgetarily in that way. And some of the reasons that costs are climbing is because we've not been particularly efficient about care. Systems don't talk to each other. Sometimes you get redundant services, as Annie mentioned earlier. Sometimes it's a person getting into services far too late to where they're already at a crisis level rather than trying to meet someone's needs earlier in the system. North Carolina has stabilized their mental health Medicaid budget costs, and that's a big deal to you as a taxpayer, believe it or not. But we haven't been able to stabilize the Medicaid costs because currently the way that is funded and the way that is contracted is very different. There's a thought that if you put responsibility and made, just as they made LME and COs responsible for the Medicaid dollars, you made an accountable care organization responsible for physical health care costs, and you matched that up and partnered that up with behavioral health care, so that's mental health, substance use, and IDD services, and you put those two things together. Wouldn't it be nice if those two systems talk to each other and work together and actually plan care around the person, rather than having to go to 13 different people with 13 different plans with all these different things trying to manage it when you're already at the most stressful place in your life? And so there is a financial accountability and risk management accountability for that. There is a discussion going on right now with Smoky Mountain, with Mission Health System, and with MAHAC, because MAHAC and Mission cover the majority of the counties that Smoky also covers. And so there is discussion about a collaboration for if in the future, if some things change at the legislative level that would allow the state to do this, would we be able to then move into more of an accountable care organization where you begin to blend physical health care and behavioral health care together to have a more unified system rather than trying to treat somebody like part of her over here, part of her over here, and part of her over here. So that's what we are expecting. It's not a done deal. As you know, Ronnie, I'm sure will talk a little bit about this, that there's a lot of politicking going on right now, and there's a lot more to go in that. But I think the ultimate goal, and I think the thing that our system, regardless of where the politics fall, is our focus is going to be on whole person care. If you haven't managed your diabetes, if you're not sleeping right, if you're killing yourself because of some of your health choices and habits, you don't feel well physically, that is going to impact how well you do with your mental health. Vice versa, if you're depressed or anxious, you're likely to do some things and not take care of yourself in the same way that you would if you felt better about that. Or you might be using substances in a way to cope that you might not normally do if you were healthier in a different place. So it's all about finding that balance. And so that's really going to be the long-term goal of our agency is, regardless of what the politics or how this play out, how can we support a person to move across the system so that they have basically one plan of care that looks at their health side and their behavioral health side.
And it looked.
I get an extra minute. No.
You can have our minute. You can take it.
I get it to
Ronnie will take it.
I don't like to sit down when I talk. I usually get up and move around. Just a little bit about the National Alliance of Mental Illness. It started in 1979 when a group of parents who had adult children still struggling with serious mental illness kind of got together, and it grew from that to an organization today that is not only within the 50 United States, but is in several other countries as well. We have 3 levels of NAMI. We have NAMI, the national level, NAMI North Carolina here in North Carolina, and our local affiliate, NAMI Appalachian South. There's 3 main focuses of NAMI. In addition to the fact that they also support research for the causes and treatment of mental illness. That's a kind of a 4th little thing that they do. But the 3 main focuses are education, support, and advocacy. Under education, there are a number of educational programs that NAMI has developed. We have several of them here locally. One of them is called Family to Family, and that's a 12-week class, very intensive class, lots of information that is given to family members of those with mental illness so that they can support their relative with mental illness in a positive way and also take care of themselves in the process. I've been there, done that with a very ill relative, and it can take a toll on your own personal health when that happens. And so it's a combination of how can you support yourself and your family member. We have the peer-to-peer class that's for the people who have a mental illness. Let me go back to family to family. Family to family is taught by family members who have themselves gone through the process of supporting a family member with mental illness, and they've received special training. Same way with peer-to-peer. Peer-to-peer is taught by people who have a mental illness, are in a good place in their recovery, and then can teach the information that is helpful to those who are taking their journey of recovery. It's a good class. I took it. I learned a lot in that one. Another educational program, and one we've been doing a lot of recently, is called In Our Own Voice, Living with Mental Illness. This is an interactive program where those of us who have mental illness and are in a good place in our recovery are trained to go out and talk to groups. We have a DVD with a lot of clips of people, starting with dark days, acceptance treatment, coping skills, successes, hopes, and dreams. It shows that yes, you can go through hard times and rough times, but you can also, through a process, learn to be successful and see your dreams come true. We've been doing that one. And as of this afternoon, we have presented in every high school, every 9th grade health class in every high school in Macon County. Almost 200 students that we have presented this program to as of this afternoon. Danita and I went out to Nantahala this afternoon and did that. It's an excellent program, but it can be for any group. And there's information up there on that. Danita is now an official trainer of people, for people. She went to Washington, D.C. to receive training, to be a trainer of those people who will be presenting in our own voice. So we're going to be having some more trainings here, and so that will make it more available to whoever would like to have this program. It takes about an hour to an hour and a half. One of the other things that we have been trained to do but haven't quite been able to put into place is parents and teachers as allies. We had this all together last year. A crisis happened with the person in charge, and we had to delay that and hope to do that. It talks about children in school and helping parents and teachers working together to help a student with their challenges. Another program that NAMI has embraced but not developed is Crisis Intervention Team Training for Law Enforcement Personnel, CIT. Smokey helps with that. NAMI is very, CIT was started by a law enforcement person in Memphis, Tennessee, to help law enforcement people who interact with people in mental health or substance use crises, to interact in a more informed way and in a way that will be helpful and beneficial to everyone involved. That's a 40-hour class. Many of our people in the Sheriff's Department have received this training here in Macon County. We also have a lot of information. We have a lot of it back here. If you want to see some of the information that we have information on all sorts of things. NAMI has expanded to talk about young children through older people and the full gamut in between. Support. Support is crucial for those of us who have a mental illness. Support is a key to our success in recovery. We have, at the local level, we have a support group every week on a Thursday. We have information about that. Tonight, most of our people from the support group are here supporting us. So we do have every Thursday night at Memorial Methodist Church right now. We have a support group because support is key. There's also call-in numbers for NAMI National and NAMI North Carolina. We have some numbers for those of us who make ourselves available to offer support by phone. Advocacy. Yes. Okay, I went on the NAMI National website and I looked under their public policy platform. This, 70-some pages, is NAMI's public policy platform.
My version's a lot better.
It covers many, many different issues that NAMI is advocating for in the government, helping us advocate for it in our communities. So advocacy is a huge part. There's some paid lobbyists in NAMI National, paid lobbyists in NAMI North Carolina. No paid lobbyists here, we just advocate. One of the things that we have advocated for and recently have been able to have is a NAMI support group in the detention center for the women. That has been going on now for about a month, 6 weeks, since February. And so that's one of our advocacies that we have been able to do here. There's a lot of other things that we advocate for. We go to the Mental Health Task Force and speak up in the Mental Health Task Force. I belong to the Consumer and Family Advisory Committee, which is a group of volunteer family members and people who have mental illness, substance use, or intellectual and developmental disabilities, who advise Smoky Mountain Center on what we think about what they're doing. We say yes or no. Most of the time it's, you're doing a good job, but we give them feedback. So that's another advocacy avenue that we have. And I'll turn the time over to Danita. I will after we do that. I'll talk about, she's going to talk about NAMI, North Carolina's legislative agenda. And how are we doing on time?
Doing great. 6.5 minutes left.
Okay, one thing before I read the public policy, we have quarterly programs at our support group. In July, we're having a doctor who specializes in schizophrenia, and he's coming to answer questions about that illness. Smoky Mountain Center is going to do community resiliency model with us sometime soon. We're also going to have something on anger management, and I know there's one I'm forgetting. NAMI's public policy platform, the abbreviated version is on the table with our information, and so is NAMI's overview of the governor's budget. I don't have time to quite present that tonight, but if you're interested in that, that's also back there. NAMI, North Carolina's public policy platform. Number 1 is advocate for increased access and funding for first episode psychosis programs. Advocate for use of screening for children and adolescents. Educate transitional youth regarding services such as individual placement support and first episode programs. Expand recovery programs. Reach educators in middle and high schools and secondary education to ensure they are aware of resources such as NAMI on campus, parents and teachers as allies, and youth mental health first aid. Support programs that allow students within the school system to have minimal disruption due to their illness. Number 2 is improve quality and length of life for those with severe mental illness through integrating primary and behavioral health care. This is exactly what they're talking about. Improve access to crisis service and psychiatric bed capacity through advocacy for more local beds and better use of existing beds. Expansion of existing capacity at state hospitals through staffing increases and expanding walk-in crisis centers throughout the state. Expanded use of psychiatric advanced directives in North Carolina. Ensure family and consumer engagement in shaping mental health services. Support an array of mental health services that are cost-effective, outcome-driven, and are recovery-oriented, such as peer support specialists. Number 3 is leverage our collaboration with the Prison Advisory Committee to ensure the health and safety of adults and juveniles with mental illness within the prison system and judicial justice system. Expand treatment model to one more prison. That's something that NAMI North Carolina is working on. Develop a dashboard report program for prisons to measure their progress. Improve treatment options to include evidence-based or promising practices. Expand CIT, crisis intervention training, to more prisons and start with parole and probation officers. Continue to support expansion of jail diversion programs. Number 4 is to develop independence and stability, reduction of emergency department usage through a system of available affordable housing. Expand the availability of the special assistance slots to help towards one more recovery. Advocate with the department to define a sustainable and adequate funding stream for room and board rates. Service array needs to include a service to provide training to acquire active, engaging community living skills. So they're not just housing them; they want to help them get better. Advocate for improved effectiveness and quality of facility-based crisis programs, ensuring that all accept individuals under involuntary commitments and operate as supportive drop-off centers for law enforcement, families, and individuals. And that's what we've been talking about, is reducing the burden on our emergency services in our police department. Number 5 is improve the economic and personal self-sufficiency of individuals with mental illness through employment. increase affiliate participation in advocating for IPS through their LME and MCO, and NAMI has had a representative attend the meetings for the employment services, 2 meetings, and we've also, I know a few people personally who've gotten work through that program, so that's fantastic. Okay, no, yeah, that's actually the last one. Mary Ann has one more.
I have a couple things. One is there's a definite correlation between substance use and mental illness. Most people who have abused drugs or alcohol have a co-occurring mental illness because that's where we're trying to use that self-medication. I'm one of those who've been there, done that. Also, I wanted to let you know about the suicide rate. I got this. It's the latest CDC Center for Disease Control statistics on suicide. Starting with the highest, we have 100 counties. Starting with number 1 is Clay County is the highest. Macon County is number 6. Cherokee number 7. Haywood number 8. Graham number 11. Swain number 21. And Jackson number 31. So you can see a very high rate of suicide, and that does not include those who have tried, but were not successful, who are thinking about it but have not yet acted on it. So I just wanted to say those are a couple of issues in addition to crisis that I personally am concerned about. We done?
Great.
Thank you all. We move right along.
All right, Sheriff's Office. My name is Steve Stewart. I run the detention center for the sheriff. I've been in that capacity since 2011. I'm here to talk today. Our sheriff's office deals with mental illness on a lot of different capacities, and I'm just here to speak about the detention center today. We could talk about the involuntary commitment process, dealing with the mentally ill as we respond to calls, but I'm mainly going to focus on the detention center today. First of all, I want to thank the League of Women Voters. Thank you. This is very informative meeting. Appreciate it. Thanks for the invite. And second, I want to thank our sheriff for allowing me to speak. It takes a lot of confidence in me for the sheriff to allow me to speak in a public setting like this on his behalf. So he's sitting here with his pistol pointed at me, making sure I say all the right things, so I'm going to try to do that tonight. When I was asked to participate in the forum, I was asked to basically talk a little bit about how many of our inmates are on psychotropic drugs, what those drugs may be, current efforts to deal with those inmates that are on those psychotropic drugs, and what we're doing about the situation. I'm very excited with what our detention center is doing. We have a lot of support from not only the community, the sheriff, our commissioners, to allow us to do some great things, and I'm going to share those tonight. But today, as of 2 o'clock, we had 51 inmates in our facility. 26 of those inmates were on some type of medications. 13 of those inmates out of the 26 were on psychotropic medications. So if you take that 51, half of them were on some kind of meds, then you half that again and they're on psychotropic meds. So we as a detention center are faced with how do we combat this? How do we recognize this? How do we get these folks on the medications and keep them in a stable environment until they're either, one, sent to a state-run facility, or number 2, released from our detention center. Pain, anxiety, depression, sleeplessness, remorsefulness. I'm happy to announce that 100% of our inmates at the Macon County Jail have those problems. And we're blessed that they do, because that proves that they have a conscience, that they're human beings. There's somebody's son or daughter that's incarcerated in our facility, and we try to portray that to them. That yes, you have committed a crime. You've not been found guilty of it yet. You're still somebody's son or daughter in our community. We're going to try to make this as painless as possible. So if you take those symptoms and combine 2 of those or more If you go to 99% of doctor's offices in America, they're going to hand you some type of prescription for a psychotropic medication. 100% of our people have those. 100%. So how do we differentiate between who we need to get medication for and what treatment is out there that can hopefully combat this and keep these people off of psychotropic medications? In 2008, Sheriff Holland was a part of this. I know several members of our community was involved in the building of the Second Chance program. I know that around 90% of inmates were questioned through a questionnaire of, do you have substance abuse, alcoholism, mental illness? And then out of those 90 inmates that were questioned, there was around 200 kids whose parents were inmates. So how does that impact our future? How do we move ahead? We have 200 parents, or 90 parents of 200 kids in our detention center. So we feel that we owe it to them to have some type of program, something informational to do while they're incarcerated. This Second Chance program was our first meeting in the detention center was in May of 2008. Mike Knighty and Francis, I would butcher that name, I promise you.
Francis 25.
But yeah, we just know him as Francis in the jail today. I said, what's Francis's last name? We had to call around and get it. Candace, thank goodness, provided it to us. But that Second Chance program provides so much more than counseling. It provides a place to go for resources that are in our community, whether it be housing, other entities, other support group meetings. And the commissioners felt that it was appropriate to fund such a Second Chance program and have continued to fund it. So as we talk a little bit about, we have people on psychotropic medications. I've identified that 100% of our inmates have those symptoms. So we differentiate by asking a battery of questions when they're first brought into our detention facility. Through those questions, we determine what a good starting point for this inmate would be. One of the unfortunate circumstances is that we place them on suicide watch. State mandated questions: do you feel like committing suicide? Have you ever committed suicide? Attempted suicide? Those mandated questions that we're looking for specific data. Also asking medical questions: what kind of medications are you taking? How much alcohol do you drink? As we previously discussed, if you have alcohol or narcotics abuse, more than likely there's something coupled with it. There's an underlying symptom of what's going on. And so we're trying to capture those questions, those answers, and make an informative decision on how we're going to first classify, house this individual, and second of all, how we're going to meet this person's medical or mental health needs while they're in custody. Reports are generated every day. We're sending them to a lot of the members of our crisis intervention team here in Macon County. We're wanting to try to get the information of the inmates, the names of the inmates, to the service providers so that they can have continuity of care when we're talking about these inmates. We have Billy Joe in jail. We know that he's been coming to the NAMI meetings. Make sure that when you come for the NAMI meeting in the jail that I can identify that person. Send them to the appropriate meeting that they need to go to. We have a local doctor that we've contracted with, Dr. Jason Creel. Anytime that we have an inmate that comes in our facility and we think that they may need some medical or mental health care, we will make a recommendation that Dr. Creel sees them. We'd like for the inmate to fill out a sick call request so that we're not violating any of their rights, we're not pushing anything on them. We want the inmate to request help, put in a sick call. Dr. Creel will come see that inmate, determine what medical or mental health needs that he may have. We use a local pharmacy to get to fill our medications. How am I doing on time? A lot of people, a lot of feedback that I get from the community is, my son is on Celexa, and he was arrested. He needs that Celexa very bad. I totally agree with you. But I can't write a prescription for Celexa. Dr. Creel has. And I always try to give them feedback. Listen, if you'll bring me those medications while we're going through this process, while we're trying to get your son or daughter's prescriptions filled, when we verify that, yes, that's what's in this prescription bottle, we'll go ahead and try to start that individual on that while we're getting them set up on our own medications. Once we do that, we'll fill the prescription. The pharmacy packs them all in little blister packs so we can track it. We'll give the medications back. Say, here, we want your loved one to have these when they get out of the facility. We don't want him to have nothing. Once an inmate is released from our custody and they do have psychotropic medications or medications, general medical medications, we try to send them out with at least 7 days so they can get in, see a doctor, get this prescription refilled. Some of the most common psychotropic medications that we have, that we utilize, Dr. Creel utilizes, is Celexa, Klonopin, Seroquel, Risperdal, Trazodone. All of those medications can be used, especially Klonopin. You know, Klonopin can be used for depression as also a medium for alcohol abuse, coming straight off of alcoholism. Writing them a prescription for Klonopin will help them with that transition to sober up. You know, an alcoholic that drinks alcohol every day for 20 years all of a sudden comes to an environment where he can't have any. That can be a death sentence. So we try to identify those needs and help that inmate through as fast as we can. Now on to the exciting part.
In 3 minutes.
Perfect. The exciting part is that we have taken a conscious approach to bringing as many resources as we can into our detention center. NAMI has started since February. At one time, I think we were the only jail in North Carolina that was allowing. We still are. The only jail in the state of North Carolina that allows NAMI to come in.
You're really pushing it in Wayne County, though.
Well, we want to hang on as long as we can. But we're the only detention center in the state of North Carolina so far that has allowed NAMI to come in. And I think that's a huge step for the whole community. We've contracted with Sarah Altman. She comes in and does some of our one-on-one assessments of people's mental conditions. Works closely with Dr. Creel. NAMI Second Chance. Huge part of our success story. AA, NA, We have a religious chaplain, Mary Ann Thompson. She does a wonderful job. We're working to bring Macon County DSS adult services into our little group. We meet, we try to meet once a quarter, maybe sooner than that, to get all of these services together. And like Smokey talked about, wouldn't it be nice if we could all communicate with each other? Who the chaplain sees and who NAMI sees, and to be able to capture some of those success stories. Yes, they were a Macon County inmate. They got out of jail. They went to NAMI meetings. They went to some of these AA meetings out in our community. To be able to capture those and tell those stories. We hear about gloom and doom of our jails and this and that. Well, we at Macon County, we want to capture the good stuff and let the community know about the good stuff that these people are doing at this table. Thank you for your time. I appreciate it. I hope it wasn't too mumble jumble.
Thank you.
Ronnie, you can have this 49 seconds.
My name's Ronnie Bill, and I'm a county commissioner elected in 2006. If you'd have told me in 2006 I'd be involved in mental health in any way, I would have said you needed mental health. But that has all changed drastically, and I would too like to thank the league for having this forum. Anytime you can talk about mental health, I've had the opportunity in the past years to talk about mental health literally all over this state. I'll tell you about the mental health task force. Some of these things you've heard from Steve, we'll talk a little about our local jail and how it has been the cutting edge and progression across this state. I also serve as president of the North Carolina County Commissioners Association, which does give a little bit of voice to mental health. That's my state initiative, is mental health. We have a statewide mental health task force now. But our local mental health task force was started mostly by myself and the sheriff. I had been appointed to the Smoky Board in 2006. Been there ever since. Through good times and not so good times and bad times. But about our task force and how important this has been to our county. Not because it's me and the sheriff will tell you the same thing, but the people involved. We put people at the table, never been to the table before together. We put providers at the table. We put the health department, the DSS, Smoky, after a while. They came for that. So we put people at the table, we talked honestly. We put people, like Mary Ann was talking about, the people who really get the services. This was in 06. So, and that mental health task force locally is going strong today. Usually at our meetings we have between 35 and 45 folks. Mostly providers, Smokies at the table, of course the sheriff's department, because it all comes back local. A little bit of the history of how we got to where we're at and why the mental health system is such a fragment. In 2001, the state decided what would be a great idea to reform mental health. You could not draw up a plan and say this is how we're going to screw things up for worse. And make a plan to do that. They did. And they will tell you that today. They will tell you that today that happened. But not everything is bad news. We have made progress. It's slow. What you find out in mental health, and I think Rhonda and the professionals will tell you, everything in mental health is reactive. Nothing's proactive. It's after the fact. We're trying to get it where it's before the fact. And we have made some great strides in that in some ways. What it comes down to is the people you're serving. No other disease. Mental health affects every family in this room. Mental health affects every family in North Carolina. It affects my family. Has since I was a kid. I'm from an alcoholic home. Affected my dad. Don't know if that had an effect on me, but I'm sure it did. So, but if it was any other disease in the world, folks, they would be studies going on, they would be things going on. Not with mental health. The only disease, you roll into an emergency room, placed in a room, however you're restrained, for 40, 60, 80 hours, 8 days, no treatment. No other disease in the world would that happen. And you can see I can get fired up because I'm not a professional. I build houses. But I've talked for the legislature, and we got some good news on that today, by the way. And so, why it is that? Well, no other disease. So what we do, we cut 700 beds out of the mental health system. We cut $40 billion out of the budget. That'll really help us. We closed Dorothea Dix, we'll make it a park. So that really, those things, but does that affect West North Carolina? Yes, it does. It does. But over time, as things have progressed, and I think Rhonda will talk to it, and Mary Ann will speak to it, and Steve, and the sheriff, the ones of us who've really been involved. On the outside looking in, many of you in this room have been involved on the first hand, and that's when you have a child, a mother, daddy, uncle, brother, sister, who needs this care, who needs this care desperately. That's who needs to be involved. So that's what we've been talking about. And locally, some things are improving. I was fortunate enough to be on the first telepsychiatric, where you have the psychiatrist, and we can talk about the chores that we've tried to went through to hire psychiatrists and psychologists. Some providers in the room. I've seen Joe Vera walk in. We can testify to that. But now we have telepsychiatry. So we have a 13-year-old in the ER. She had overdosed on some medications. So that was the first one we had in Macon County. That's been about 4 months. And it worked well. It really did. In other words, there's a camera on, we find the patient, and the psychiatrist is on the television, and they talk. We think this should be in every jail in the morning. There's no reason it's not. No reason. The millions of dollars have been spent on mental health. So, but now what do you do after they're diagnosed? Well, the sheriff didn't get into the numbers, but he would tell you the man hours real quickly and what it costs Macon County in just a transfer of people from the ER, sitting with them in the ER. It's going to cost you in this previous budget about $280,000 to the sheriff's department out of his budget that he did not come back and ask for more money for, by the way. He used his money out of his budget to pay for this overtime for these folks. But, so where are we today, and has it progressed? How am I doing?
Great.
So, so what's going to happen? What do I think is going to happen? I tell you what I think is going to happen. I don't think you'll see many more psychiatric beds put in place. I think that can be a good thing if on the front end they do the right thing. I think if on the front end, if the care is there, and we're going to talk a little bit about that here in a second, if you do the care up front and make sure, then we're going to talk about stigma of mental health. That, folks, is the worst thing that can happen to mental health, is the stigma. And so we're going to talk about that. And so let's talk a minute about what we're seeing locally. It's not uncommon to have 6-year-olds in voluntary committee in Macon County. It's not unusual at all to have teenagers, several teenagers. The youngest I've been with is 6 years old in voluntary commitment. Now, why is that 6-year-old been in voluntary committee? Michael just spoke along. Michael don't write the story. The grandmother was raising a child. The grandmother we dealt with the child before she was called. I do go to the ER. They think I work there. I mean, really, these people I go see. And when you sit down and talk to the families, mental health is like any other tragic disease. It affects every member of that family. This grandmother was raising a child. Long story short, the child needed help. Macon County Sheriff's Department transferred that child to Wilmington. Stayed in Wilmington 13 or 14 days. The child is doing better, doing good, doing a whole lot better. But if this child is 6 years old, now whatever you hear about the state and the money, forget about everything else. If this child is 6 years old, does not get the proper care for the rest of his life, how old is this child going to be? 50, 60, 70 years old. Who knows? Your tax dollars will be taking care of this individual for the rest of his life. So, there's a surplus now. Of course, and I was in Raleigh with the governor now. I introduced the governor. I had a chance to introduce the governor. We talked about the money. Of course, the first thing I hit him with, we need to put that in child care and mental health. That's where we need it at. I mean, if you don't take care of the children and the young folks, you're going to have to start somewhere. You're going to have to. And with these young folks, Macon County, we're very, very fortunate, very blessed to have providers who look after our students. Paula Ledford, who works in the school system. You hear the suicide statistics that Mary Ann quoted. Those statistics, now you got to take that in perspective of the population, of course, but one is too many. One is too many. So, but if we hadn't had in force Macon Psychology, Burn Springs, Meridian, Appalachian, Jackson Psychology, if these folks hadn't been in place, those statistics would be much worse. I know for a fact they would. So we're talking about young folks. We're talking about 15 and under. When you get to the mental health thing, 16-year-old, that's a different little ballgame. So where do we stand now in Macon County, and how are we doing it? We're doing much better. We have a walk-in clinic. We have things that Rhonda talked about that 4 years ago did not exist. What's our biggest challenges now are really simple. Is mental health is that you got to recognize it as a disease. Until that stigma is overcome, or we work on the stigma. Growing up, I'm born and raised in Macon County, and you looking back, you can see members of the family, whether my daddy, coming out of World War II and self-medicated the rest of his life. I realize that now. That's what he did. I realize that now. So it's been an education for me, but nothing like the Mary Anns of the world who deal with it every day. I can be on the outside looking in, I can beat the drum, but these are the people that matter. And this younger generation coming on. I've got so involved, I showed it to Stevie. When they send you the report from the jail every 2 days from the state, you know you're pretty much involved. This comes last night, North Carolina prison, Mr. Bill. We want to keep up because we talked about prisons and jails. As of night before last, we had a little over 5,000 inmates in state prisons now that were truly diagnosed with severe mental illness. 5,000. Now that does not count the county jails, which I guess there's some big central jails that's not counting the state population. That's about 15 to 18% of those incarcerated in North Carolina in state prisons are diagnosed. These are folks who, Stevie talked about, the different kinds of, but there's all levels of mental illness. It's not all substance abuse. It's not all schizophrenia. There's many levels of it that I have come to know. But the jails is your mental health hospital. Good. That's where they're at. Now, out of those, that's about 15 to 18% of the inmates incarcerated in state prisons. Not counting the jail that Officer Stewart runs every day. Very well, may I add, you're very blessed to Macon County to have a jail system like we have. The actual number of mental health over the past 2 years since we started keeping real records, and since I started asking for them from the Division of Prisons, we said never had nobody asked for that. The number is actually coming down because the number of prisoners is coming down. But in relation to who's there. Now, who are they? Now, let's talk about men and women. The women will tell you, as they come out, it's over 30%. They admit to a severe mental illness. Now, this is diagnosed mental illness, not just, you think, 30%. So the prisons is acting as that. And you're going to hear a lot. You're going to see a resolution come out of the Macon County Board of County Commissioners on a whole foot price called Stepping Up. I also serve on the National Association of Counties Health and Human Services Board. And you can guess what I talk about dialogue. So this is called Stepping Up, and it's to recognize that jails is our mental health system across it, not only Macon County. You hear Stevie say 100%. So, but it's going to go nationwide. This is every county in every state. And not just that comes from me, but I want the folks here tonight to know that without the mental health task force, without the support of this man right here, and us working together, and a lot of folks in our county. But now, I think mental health task force are in at least 30 counties across our state. We were the first. And our state mental health task force, which I appointed a statewide mental health task force to look at how, where we're at in the state. That report will be given in August of this year. Now the good news. I got a call today from, if you read the paper, you saw where Dave Richards was in town. Dave Richards from DHHS is Behavioral Health Secretary, Undersecretary. So he's pretty much the head man of mental health in North Carolina. And the Secretary, we had a long talk today. They are $30 million in this year's budget. So for the first time in a long time, $30 million bucks. Of course, my reaction was 10 million short, but now that's still got a long way to go. But the $30 million that's in there, the only thing we're going to ask for is county governments and representing the closest to the people is we need to have access to that. Smoky Mountain has went 180, as Rhonda will tell you. Smoky Mountain is an insurance company. More or less, that's what they do. They take the money, distribute it out to the provider. One more thing, real quick. Two things real quick. I won't bore you with that. The providers, if it's not for the providers that we have in our area, and what they do, and what you need to know, and I can list them all: Appalachian, Marion Springs, Jackson Psych, Macon Psych, other folks. What you need to know about these folks, Meridian, 30 to 45% of the people they see, they never get a dime to pay for. Did you everybody understand that? Just ask them. I saw the number. 35 to 45% they don't get for. No other business in the world, if you're sitting in this room and you run a business and do 40% of anything free and have a business. But these folks do it. Why do they do it? Because they cannot turn away these folks, pure and simple. We've got to get providers better pay. We've got to get providers where because they're the ones where the rubber meets the road. I mean, they have to work through Medicaid and that bureaucracy, but if you see a provider, be sure and thank them for that. We promise we'll be working on 30 million stigma. One last thing. When you see this, I've held this up all over the state. This, you know, we're going to be making progress. We're going to have a benefit dinner for Ronnie and Bill on Saturday night at any local school. Ronnie is battling mental health illness. We'll have hot dogs, hamburgers, chips, and drinks. And then when you see this in your church bulletin, on your convenience store door, anywhere you see a bulletin, you've never saw a bulletin like this, ever. When you see this bulletin, we've made progress. You know that the stigma is slowly going away. But until you see this, and we can feel comfortable talking about it with each other, we've not made much progress. So we look forward today to this poster. I appreciate you listening. Thank you for being here.
I'm Cindy Soulsby. I'm a healthcare navigator from Mountain Projects out of Waynesville. And our director, Patsy Dowling, applied for a grant in 2013 to hire us navigators to be in the furthest, most western counties of North Carolina, in the most rural areas, to help folks get through and sign up for affordable health care. So, and she came to that conclusion that she wanted to do this. A big motivation for her is that she found out that there were approximately 30,000 uninsured in the far western counties of North Carolina. So we have a navigator here in Macon, me, and we've got Clay, Cherokee, Haywood, Graham, Jackson, and Swain. And what I do is I help people get through the application. We apply online or on the phone. And really what you're applying for are premium tax credits or subsidies. That's what really makes the insurance affordable. Not only are the premiums that make the insurance affordable, but there's also cost sharing reductions, which means if your income is within a certain amount, you pay less for co-pays, deductibles, and your co-insurances. So the least I've seen for Blue Cross Blue Shield is like a $5 copay to see a doctor instead of $25. Oh, okay. Or $10 instead of $50 to see a specialist, and $500 deductible instead of $3,000. That's the best I've seen. So this truly makes it affordable for people, and especially people that I've seen who've never had health insurance before. Now they have it. So this Affordable Care Act provided protections for people, for consumers, that they've never had before. It prohibits premiums going up because of bad health or your gender. Typically, women pay more for health insurance. It extended coverage for young adults until age 26 on your parents' insurance, which is really important. We're talking about mental health and young people and substance abuse and the things that they experience at a younger age. And this is really important for them to be able to stay on this insurance. It has to cover people with pre-existing conditions. So typically we don't think of mental health being a pre-existing condition, but it is. And so if you had a substance abuse or mental health conditions, now you don't have to worry about that, you're covered. It eliminated annual limits and lifetime limits. There used to be a limit on your insurance that would say, well, when we pay out $10,000 a year or $1 million over a lifetime, those limits are gone. There are no more limits. There is a limit as far as how much you pay out. The lowest limit I've seen in an entire year is $700. That means that all your co-pays, your deductibles, your co-insurances go towards that amount, and you're done, no matter what happens to you in a plan year. I had a friend who was in an ATV accident. It flipped over on her, and she was put in the hospital. She was in the hospital over 2 months, and she had 2 brain surgeries. And then she went to Care Partners and got therapy. But her bill, I know, must have been over $1 million if you're in, the hospital that long with that care. But $700 was the most she paid. She's a farmer, and her husband didn't understand the insurance, and he thought that they would have to sell their farm, literally. But they didn't, thankfully. Now, these plans have to cover a minimum essential benefits, and these are outpatient services, emergency services, hospitalization, maternity and newborn care, and this is important, mental health, substance abuse, behavioral health treatment, prescription drugs, rehab, labs, wellness management, chronic disease management, and pediatric services, including dental. Now, these, it used to be insurances either would not cover mental health, or if they did, they would only limit it to like 10 visits a year. And now, due to the Parity Health Protection Act that was passed in 2008, insurances, when they offer mental health, it has to be on an equal level with physical health. So, in other words, in the instance of like co-pays, they have to have equal co-pays. So, in other words, they couldn't charge you $40 to see your psychologist and $20 to see a doctor. These have to be equal. And they can't limit, as I said before, they can't limit the number of visits that you go to for your mental health treatments. So, it's like thinking, what if they limited your treatments for high blood pressure? I mean, that doesn't make sense. So now, mental health issues are on the same level. So, let's see here. I'll go fast here. All right. Okay. Let's see what else. Okay, another great benefit for this insurance is preventive care and that pocket cost. And part of that is screening. So you have screening for alcohol, substance abuse. They can screen at the very first, no out-of-pocket cost whatsoever. So that makes it very affordable and encourages people to go see it. So right now we're open enrollment is closed, but we have special enrollment periods. So those for people like you have a life change, like you get married, divorced, you have a baby, you leave incarceration. That's a special enrollment period. So here's all the. If you know of anybody that might fall in these categories, please take a flight. be glad to help them. Thank you so much. People think I sell insurance. I don't. I don't get any commission. My commission is knowing that people are getting covered, and you can't put a price on that. Thank you so much for having me.
They did great, didn't they? This is wonderful. I want to thank the panel and all of you. I know some of you have questions, and
I just want to announce something real quick. Like Monday at 10 o'clock in the town hall, the town and the North Carolina Harm Reduction Council are giving a training, and we've decided to open it up to anybody that's interested. Originally, it was only going to be mental health professionals and law enforcement. However, and this training is about naloxone. Maybe you've heard about it, maybe you haven't. But as they were talking about, 100% of all inmates just about have played around with some kind of drugs. Prescription drugs are a lot cheaper now than the illegal drugs, so that's one reason they're going to the prescription drugs. So, naloxone, if we can get to a person that has overdosed and they're unconscious, we can spray this in their nose or we can inject it, and in about 10 seconds they're out of that whatever they're in. It brings them right back around. There's been some controversy because, as usual, there's been the folks that come up and say, well, that'll just make people want drugs more, knowing they can live. So this is the type stuff we deal with on the war on drugs. So if you're interested in it and you want to learn about naloxone, we sure hope you'll come here at 10 o'clock Monday morning. We'll have police here, so there will be donuts.
okay, other questions? That was an announcement, but other questions on the floor?
I have one for the detention center.
Yes, sir.
Is oxycodone, is that still on the market?
It is.
Do you know why? Mr. Neal?
Yeah, well, oxycodone, and I don't want to jump in front of Stevie, but you know, it's an opiate, highly addictive, and really still readily available. Florida has curtailed it somewhat in their prescriptions. Not many years ago, I used to X-ray of my bad knee. We went down to the little thing that you just changed the name on it. We could, when you opened up the Orlando Sentinel, I guess it is, where you saw like vitamins, blah blah blah. This was pain clinics. So it was just a train. But now that in Florida has been curtailed somewhat, but it still comes out of the prescription book, the opiates. And for opiate addiction, there's really only two methods: methadone or Suboxone. Now people have different views on that. I am an advocate for Suboxone. It is just like methadone. It is a substitute drug, but it's not an opiate. It's a synthetic. And if it keeps you from taking that opiate, and the idea of Suboxone, which you didn't hear that listed, still as medication because only certain doctors can prescribe that for opiate addiction. You have to, I think the closest one to us is probably Waynesville or maybe Asheville, Waynesville. And so we have several that I know for a fact in Macon County that's taking the Suboxone. And there's different views and opinions on that. Yes, you're substituting one drug for another. But at the end of the day, the recovery rate from opiates is almost like that of methamphetamine. It's really low. The percentage is really low. So anything that helps that. And with Suboxone treatment, the studies are now coming through that it does help. And so we're hoping why they don't. They come from prescription pads. That's where the oxy comes from and the other opiate-based drugs.
Thank you.
Yes.
Why do you think there's such a high suicide rate in western North Carolina? 6 of those counties were in the top 25.
Anybody? Y'all?
Yeah, anybody.
I think one of the reasons actually the percentages, I agree with Ronnie, I think one person is too many, but one of the things that we do see is
Unfortunately, Western North Carolina in general, because also some of the other Western Mountain counties, tends to be a destination spot for people that are choosing to end their life. So many people come to the mountains to do that. Also, if you calculate that percentage, if you, yeah, it's, and then I think the other thing too is for people that are local relative to the size of their population, if you have 5 people in Charlotte versus 5 people in Macon County, the percentage just by the proportion of number is significant. Again, that's not to minimize it. I think there are some very real issues here. You've got the economic factors. You do have very real pieces with, I think, mental illness, depression, substance use, any of those things can certainly be part of that. But I think, unfortunately for us in North Carolina, the mountains is sometimes a place that people come when they're having a really difficult time, and that's where they choose to finish their life.
And if I could say one thing added to that, if that number scares you, then you'd really be shocked it's a true life number, because the actuality of it is those are cases that they can confirm are suicide, 100%. That person that you go into, the officer goes into a house and they're dead, and it turns out that they died from an overdose, they're not considered a suicide because they have no way of knowing that person definitely committed suicide or not. So the number would actually be much higher. And I know you all know that, but I'm sure you all might not have known that.
And if you do the rates, the population of Clay County compared to the number of suicides, that's what the data that they got. And in Macon County, and Rhonda has a good point, but it's hard to prove that. I know here in Macon, the sheriff does too, that we've certainly had more than 1 or 2 of those cases where people come here just for that purpose. But what's concerning about all the suicide rates is the age. I mean, I'm 59 years old, and but when you look and see, and I know for a fact that what's been attempted, as the sheriff does too, what's been attempted with our youth, not only in our county, but surrounding counties and statewide. That's what's really alarming. And we see it going trends. And it's like the cutting trend. We're seeing it make a comeback now with kids. We found a wonderful place to take them to South Carolina, by the way, and I guess the providers here know about that. But the suicide rate is for older adults who don't, they don't have somebody to see them. But in the schools, we thank goodness in Macon County schools, we have good folks who watch out after them. And let me just throw this in. It has nothing to do with mental health. We're talking about our budget now. The state just come down, the schools just come down with their budget about teacher assistants in schools. Folks, I'm telling you, if you don't see these kids and try to identify them in 1, 2, 3rd grade, you're going to be taking care of these kids a long time. So when you see this budget come out and however it ends up, that teacher assistant in that room, the world has changed when it comes to school. And who's in those rooms the other day. When you go to most rooms now, these kids go here, these younger kids go here. Why do they go back here? These K-1 kids to comb their hair. You've got a dedicated folks who stand at the end of the hall to comb these kids' hair, put their shoes on the right feet, make sure the shirt's not on backwards to prepare them for the day and wash their face. You never seen that when we went to school. Nobody's food in. So that's where we're at. So if you don't have those, I don't know why I put that in there, Stevie, but these teachers said that's the reason we're going to be advocates for that, because the more eyes you have on these kids in our county, in every county, I think it's worth it. And I think in the long haul, that will help that. But if you don't, we got to go back to the youth, and that's where we're going to have to change this. For everything from stigma to the treatments and how we handle it. I really believe that.
If I can add to what you said, mental health first aid, I think is actually something that communities can do. That's something that a layperson who's trained in that can you talk about it, early identification, able to intervene in the situation as it comes up. Mental health first aid has actually been shown in community intervention that reduces overall incidences of stigma, and that's something that's available to any community member at any level as long as they have that training.
Anybody here could take the class. It's a day-long class, one for if you're talking about intervening with young people, teenagers, middle school age, and then there's a separate class if you're talking about reaching out to adults.
And that's advertised in the paper? Or
yes, and on our website, and there's a little description of it, and it tells you who to contact if if you have a group that wants to take the class, we can come out and teach it to you, or put it on for the community.
Two other interesting suicide rates, I don't know if they were listed, but when Ron Williams died, what was identified as the top growing suicide group was men over 40. And then we're losing a vet every 22 minutes to suicide.
It's 22 veterans a day, but not 22 minutes.
She's talking just about men over 40, you're not
No,
talking
both
about
groups.
veterans. Okay.
Well, 22 a day is even one every
22 veterans a day commit suicide.
So that's a whole lot more than one.
22 veterans, and not here, but throughout the United States. 22 veterans a day commit suicide. I just got that email today.
How does that compare to the general population?
It's much higher.
Way higher.
Way higher. For a single
It's
person.
probably the highest single group I would say.
Highest single
For
person.
teens and for young youth, it's the third killer of youth, suicide. After growth and driving.
In Macon County, what's the average age or mean age?
For suicide, I wouldn't know, I wouldn't have that, I wouldn't have that information, but thank goodness that, well, any suicide's terrible. It's a terrible way, terrible for the family, but the sheriff can answer that better than I can.
And I have to answer the same way he does. I don't know that number right off the top of my head.
Well, again, it's very hard to identify. Like you said, you can't, not a lot, somebody could drive their car into a tree and it's a suicide, but it looks like a single car accident. So it's also hard to tell.
Yeah.
And the veterans are not being forgotten in the suicide watch, and what we're seeing statewide, because, North Carolina is a huge military.
Right.
A lot of these young people coming from Afghanistan, Iraq, Iran, they're really struggling. You have the Vietnam veterans, it took 40 years to recognize their, what they did, the sacrifice they did for their country and to be accepted. Still working on that. So these kids are coming back, and they're not really connecting. You got Mr. John Crawford back there, who is now the oldest veteran in Macon County. John Crawford has also been involved for over 70 years with the VFW. These younger people coming out are not connected. And they're, if you went and saw the movie that we all saw, and, where the young man, he came back, was mentally ill, and we're seeing that probably in the military, especially in Fort Bragg, and the others. And these are younger folks from the military. And so that's a real concern. And hope the VA, I think they're making attempts, and it's hard for local governments or even state governments, when you with the military, that's what we're seeing is those. And I think that I got the same email Mary Ann did, and that's what they'll tell you in that email. The rate for these younger folks coming out of them is really high.
Hey, can I ask you to change the subject just a little bit for a minute? What do we know about the mental health needs of the Hispanic and non-English speaking people in Macon County, and what kind of outreaches do we have towards them?
You want me to answer that? The best one we have is the community care clinic. Our community care clinic is based with mostly volunteers. The county does put some funds into it. Those funds have been decreasing. We have some dedicated folks who work through it every day. But that is the first line, because that's usually where they will go to get treatment.
Ryan, is that bilingual?
Yes.
Yeah, usually.
Yes, most of the time, yes.
Do we know anything else about that population, the kinds of programs we provide to our children, the kinds of programs we provide to our adults? Do we provide them also bilingually, or do we know if they need them?
Yes, we do in the schools. As a matter of fact, the interpreter at the schools is out on maternity leave. We're having for the sheriff's interpreter now to go into the schools for the Hispanics who might have mentally ill problems. And of course they work through a local provider to do that. But I think that area is that population, that population can go like this real quick. And I think there are some efforts being made. Do I think that effort is it's hard? different folks have different cultures, and to break through on that I think that's going to be a while. Of course, these experts can tell you more.
Well, there was a listening session, it was in the newspaper, that they asked the Hispanic community, what do you need? And mental health care was one of the things that they came up with.
I wanted to just talk a little bit about what Southwestern Community College is doing for mental health. We have a student assessment team that has psychology instructor, the dean, human services instructor, and we have a portal on our website where any student or faculty member or staff member can put in a concern about a particular situation, which is the behavioral health, and that comes to the team, and then we try to help that student maybe go to Appalachian if needed, or whatever is needed. We also have counselors on that. So Southwestern is very much involved in trying to be on the front, to assess, and to be able to help somebody before it gets way out of hand.
This is just a wonderful example of something that wasn't going on 2 years ago. So it's coming on. We're going to see that banner up. We're going to see that poster in the store before long.
Commissioners, just to add on to Sarah and SCC, I spoke with Sarah the other day, and one of the main things that we've identified as a peer support group in our jail is for kind of like a continuity of care coordinator. And I talked to Sarah a little bit about that either this week or last week. And we're thinking about having some of her students at SCC serve in that capacity until I present it to the sheriff and he presents it to you guys about funding a coordinator for these services that we're doing in the jail. So just to caveat what she was talking about, they're going to help in that aspect as well.
Yeah, just a personal kind of situation, and I've never dealt with this before. We have a neighbor that is extremely disturbed. He was involuntarily committed by his family on our calling the family. He was taken to the ER, and then he wound up in Winston-Salem and had 5 days of treatment and was released. He's back. I don't know if he's any better, but he's extremely angry. He doesn't want to talk to us because we basically initiated the process to commit him. And I haven't heard yet, is there a program for friends of mentally disturbed people? I've heard family support, peer-to-peer, but how does a neighbor relate and deal with this? Because I'm at a loss right now what we're going to do with him and how to deal with him.
Family to Family is a great program, and we're just finishing it up. Back to Mental Health First Aid is another great tool, just some general how to deal with that kind of situation. Family to Family is 11 or 12 weeks. It really gets in depth, and we say family members, friends, or loved ones. But it's basically anyone that has any kind of reaction.
I mean, how effective is that when he does not apparently even believe he has a problem?
The secret of the class is they'll tell you how to take care of yourself first, basically.
Okay, that is a challenge, is a person being willing or able to accept that they have a mental illness. Part of it has to do with stigma. Part of it has to do with the brain. Dr. Amador. Dr. Amador has done a lot of studies about people being able to recognize. He did some studies, he's a psychologist, he did some studies on people who had stroke. And there were people who had a stroke, and even though you showed them a video of the fact they couldn't raise their arm, they would it's because I'm tired. Somebody's holding my arm down. Even with a video showing them that they couldn't raise their arm, they weren't able to accept the fact that they were not able to raise their arm. he had a brother with schizophrenia who would not accept the fact that he had schizophrenia. He has developed a lot of resources, a lot of ways to handle that. I'm on his.
He wrote a book.
He wrote a book.
I'm not sick. I don't need help.
He's also, yeah, he's also written. He has a website that you can go on and gain some information. One of the things he points out is don't always concentrate on the mental illness. Concentrate on the whole person. Develop a relationship with that person that goes beyond the concern for the mental illness. And that is one of his key points, is to develop a relationship that doesn't always pound in the fact that he's got a mental illness, but try to develop a relationship with him over and beyond that as a whole person. That's one of the things that he talks about. But he's got some really good strategies for people that will help you relate to someone who either will not accept it, and sometimes it takes a while to accept it. There's some of us here that have been down that road, not willing to accept it, to the point where we can. And again, sometimes it has to do with the brain and what part of the brain is affected.
But you hit on something else too. He had 5 days of treatment, sent home, probably with medications.
He's not taking.
Right, yeah.
So he's going to end up bad. He'll let, and that's another problem. That we see the same. We see it. You know, it's revolving door. These folks. They come back to medications. They don't like to take the medications. They readily admit. Marianne will readily admit they don't feel right when they take them, so they don't take the medications. And how do you? You know, that's where they got to be a system developed. And it's almost going to be like if you was having, I hate to compare it to anything, but you having chemotherapy. There's a follow-up process. Always. Time after time after time. This should be no different, in my opinion. That you got to be a follow-up program for these medications. Because you'll see that the folks, and we have some numbers on that, of the folks who locally will come back because they're not taking the medications.
And even
Especially that time period, that first 3 weeks, right, Rhonda?
It is, but even if they have follow-up, the thing about adults, if you're considered a competent adult, they have the right to refuse to take their medication, they have the right to refuse treatment. So you can have everything laid out for somebody. You can have an aftercare appointment, you can have medication. An adult can make the decision to not do that. And I think if any of you have ever struggled with the diet,
I'm not.
Sometimes it's easy to sort of say, oh my gosh, that's such a bad decision, that's bad. But if you've ever seen somebody walking around with an oxygen tank smoking, or if you've ever seen somebody who's had a heart attack, who is enjoying the Ryan's buffet to their heart's content, I think the thing is, you talk about stigma, people sort of make conclusions about that person's goodness or badness on the fact that they don't get treatment. But I think if you think about a public health model, many of us know there's many other ways that we should be taking care of ourselves. And we don't, even when there's any serious consequences. And that's without having your cognitive processes impaired chemically. So imagine how much more difficult that can be to accept that this piece of yourself, this part that makes you you, to acknowledge that somehow, because there's that shame process for the person first, and you have to get past, this is not about me being bad. It's about I have something that needs to be treated, just like I might have cancer, or I might have diabetes, or like that. But we judge ourselves first, and other people tend to judge with us. So it can make it a really high-risk situation.
But don't feel, there's a good possibility because of your phone call, that family, whatever, you might have saved this person's life, even though they're mad at you now.
Yes.
And don't feel, and when you deal with the families, as Nami will tell you, that that's not unusual. I mean, they'll come out and, they not happy campers. So
sometimes that madness is just embarrassment. That's their reaction.
Yeah.
The compliance rate for any kind of a condition is not the best.
I just think about how many people don't take their antibiotics.
Yeah. You know, I was behind a man in the grocery store buying this, what do you call the ham that's got lots of salt on it? Country ham.
You have to make the gravy with it.
I can't eat that because I have high blood pressure. He said, I have high blood pressure too, but I just take my medicine and eat anything I want to. Okay, so the compliance rate with any kind of a condition, health condition, is probably not the very best. It's just that mental health has more stigma.
Mr. Bills?
Yes, sir.
I wanted to personally thank you for what you're involved in locally, statewide, because I know you've got a lot of weight you can swing.
How's that country ham, But that's, I've never been involved in anything like that. I really and truly. Mental health is it's treated differently, and when you're outside looking in, the more you get involved, and the way it affects a lot of folks. But I've worked with a lot of good people, and we've seen a lot of good changes, and we think there's more to come. We think that this, I really and truly believe that just having talks like this in our community, 10 years ago, we never had this. 5 years, we never had these talks. We had them in jail with Robbie. We'd go with Stevie and sit down and have these talks. Or we'd have them with the provider that said this, or with Smokey. And so things are changing. People are beginning to realize. And one of the things that we super worry about, of course, the state has proposed 4 large LME MCOs, if you will, local management entities, management care organizations, for the state. In other words, it would go from Cherokee County to Winston-Salem would be our area. Not necessarily our area. There are now 3 LMEs in that area. So myself and the VSS director from Buncombe County have been designated as the ones who negotiate with these other 2 LMEs. That's went real smooth. So it's a real, and the state don't really know what they're going to do. We personally, if they want to expand that, fine, but it's got to get back to the local level. We had a pretty good system. It worked well. Mike Knighting done mental health here for 35 years, almost by himself. Don't think Mike could do it now, but it's still got to get back to the local level. We'd like to see the Balsam Center become a respite place with 10 beds. But Haywood County has 17 beds. They're full tonight, I'll assure you. Guarantee they're full. We need those beds for the Jackson County West. We need those beds today. So we're going to make a push for those beds. We're going to make a push to change the jail programs. The jail program that the Macon County citizens are paying for, we do for around $20,000. We could not get what we wanted to do approved because it didn't match the criteria that the state had given down to the LME. So we tried to streamline that, get the person that needed the help. And the second change program, we're using that sort of a model, and we're asking that to be rewritten on how you handle in jails. And let me just say this while I'm running my mouth. You don't know how proactive Macon County is in the jail system about that in a lot of ways. I mean, we were over to jail yesterday. And when you see these people that's incarcerated, the most significant thing Steve Stewart said all night, did you hear the number of children that their parents are incarcerated in Macon County? Did you hear that number? 90 children?
200 children.
90 inmates. You need to think about that tonight. If you don't take nothing else away from anything that's said here, think about the children that have a parent incarcerated. You know what that home life is for that child. So there's a lot to think about. But we're so blessed in Macon County to have a sheriff's office that's been proactive and willing to step out and do things differently. And to have a group like NAMI, who, and the sheriff can speak to this if he will, without the knowledge training of our officers, deputies of Macon County, has probably prevented, I don't know how many involuntary commitments that has helped because of the training from NAMI to our officers. And I think every officer, Sheriff, you can correct me if I'm wrong, has received that training. And we're one of the few counties that's done that.
We're one of the highest in the state as far as percentage of officers.
So and it's took a lot of folks working together, and it's a slow process, but we're still working. I appreciate that. We'll keep working, I promise.
Well, just a final comment for you, sir, that this group may not be aware that years ago when the Folsom Nursing Home was purchased, over $400,000 was spent to remodel that building, and the entire right side was a child abuse center. Tables, furniture, and everything were cut down to children's size. It operated for about 6 months, and the state and every other people shopped it. But it's available, and I would like to see you swing some more weight. Let's get that thing opened up the way it was designed. I think we've got.
I think there's an opportunity there for those in the far west. The suicide numbers you hear should be enough evidence alone. And but another thing we need to talk about before we leave here tonight, is something that's not been mentioned, is foster care. There is one level 3 foster care home left from Haywood County West. One. Now, level 3 foster care is the most significant foster care they are. I mean, it's almost constant supervision. The child has had problems. But to have one of those homes, now level 1, 2, we do have some, and we got some more coming online. But believe me, the number of children needing foster care and the number of foster care homes is totally out of balance. And another alarming thing that you're seeing, not only in our county, but across the state, is how quickly parents are signing their kids over to the ward of the state. Like you're signing a credit card application. You cannot make it up. I sit and watched them. Me and the sheriff sat and watched one not long ago. 13-year-old kid, good-looking kid, made good grades in school. So he's now at the clearinghouse. So if you're in line to take a 13-year-old foster kid, you don't know what this young'un has seen since he grown up for 13 years, number one. And so they're not exactly supposed to stand in line to take these children in. So foster homes are a real challenge, because most of the time in this day and age, for families, it's hard enough for them to survive with what they have. To bring in foster kids is something else. So just another challenge that we got to, if we don't rescue the children, the rest of it don't matter.
So where do they go? Is there an orphanage?
Well, they don't call it that. Yeah. Durham, North Carolina is where a lot of them go. It's called, clearinghouse is not the right word, but they go there, and it's called a transformation. They got a politically correct answer. It's where they put the kids where they try to move them on. And so then they're distributed out to different places throughout the state in hopes that they can find a local home.
Institutionalized.
I didn't want to use the word, but Mr. West took the words out of my mouth. Yeah. And as these kids get older, of course, now what's going to happen in North Carolina? They're going to become an adult, and they're going to give a package. Now they're getting educated, or hopefully they're doing all they can on the state side. But you worry about that, because these kids are going to become adults, and when they become adults, they'll
be institutionalized,
and they'll end up back there if you're not real good.
Right.
So, more do we?
I have a question related to substance abuse. I do a lot of work with people who are needing help. And the only resource that I've been able to find where I live is a hospital emergency room. And I'm real curious how I go about finding out more information about how to get help for people who can't afford to go to bed or go to treatment center.
Are you making? You didn't make it?
I do. Yeah.
Did you hear me quote that 35 to 45% that they take care of the providers?
Yeah.
Unfortunately, the first line of defense, is involved their commitment. Get them in do you want to go that process, or set them up, or have them go to the walk-in clinic. Have them, the walk-in clinic. Well, if you know in Macon County, do you know where Jim Brown Chrysler, the old health department up on the hill, the Evergreen Foundation has a building there that they give, and it's run every day by Appalachian Mental Health. It's staffed every day. We really think it should be staffed 24/7, by the way. So, but if you can get them to the walk-in clinic during the day, they will help you. And then there's some folks at Smoky that can also help you. There's a helpline at Smoky. Don't be afraid to call that at any time. And 24/7, somebody, a real live person, will talk to you. Or call my house at public.
The phone number, address.
Just call me or the sheriff. That's where most of them call.
That's one of the reasons we started the Second Chance program, is because a lot of times with the substance abuse, these individuals are meth out of their heads out here on the street, and when they come to their jail, they're still meth out of their head. But then they're there a few days or a week or two or a month, and they get their system clean, and then they start realizing how bad they're screwing up and where their life is going, and they start asking for the help. And we just didn't have a good avenue for them to get that help. And so that's why we wanted to start the program within the jail. So today, while they take that program in the jail, this evening at 4 o'clock, when they bond out, they know that person that they've related to for these last 3 weeks, these last 6 months that they sat in jail, year, that when they get out, they go straight to their meetings. They know all that.
Candace, not Bering Springs is one of the providers that focus on substance abuse. Bering Springs.
We have several providers here. I'd like to certainly recognize, I know Candace from Bering Springs, Joe from Meridian. I'd like these folks to stand. If they stand up. This is your first line of defense of mental health, folks, right here. If you're another provider, would you please stand? I don't see nobody from Appalachian here, but if you don't know these folks, they work, there's some of them folks that run, if they don't deserve a hand, folks, this is your first line.
Also, Meridian has what's called a recovery education center, free to anybody. There are classes there for anybody to take. When you go in, you have an assessment, and then there's a lot of resources there. There are peer support specialists there who are people who themselves have had mental illness or substance abuse who are in recovery. There's clinicians there. There's medication management there. And they also have classes people can take there. And again, if it's not, you don't pay for any of that, but they can help a person with whatever. There's a lot of different classes, the RAP classes, the
Wellness Recovery Action.
and there's a lot of other classes there that can help themselves. Meridian. It's below, Appalachian's up here in the old Smoky Center, and Meridian Recovery Education Center is down until about.
And don't be afraid, I admire the neighbor that called. If it's a family member, there's folks, maybe we've done a poor job of getting, how can we reach out with the walk-in clinics? But it's available. And we're going to make it more available. We want it 24/7. It's closed on the weekend. When's the people leave the hell? I beat that drum too. But we're slowly but surely, like one bite at a time on that elephant. We'll keep eating. And so, but don't be afraid, just like the neighbor that was willing to make the call to the family member. Don't be afraid to do that. You won't do it out of spite. You won't do it out of bad judgment. You won't do it to try to save that family or that young person.
I think this is a good time to move around probably. I want to, first of all, thank you all very much for your expertise, your passion, your dedication to this important topic. And I think we've all learned something tonight. We have opportunities to learn more. We've learned about how to do that. Don't forget Monday at 10 here And also, there's material all around here where the aldermen sit on a regular basis and help yourself stay a little while and pick up some information. I just wanted to thank again. Thank you.
Thank you.